Good morning, everyone. It's really a pleasure to be here. Thank you so much for inviting me, and I do apologize for being late. I got stuck in traffic on the way from Kobe, so I do apologize for that. Thank you very much for Dr. Kihara and the team to inviting me here this morning to talk a little bit about implementation science. My name is Sarah Barber. I'm the WHO Kobe Center Director. I'm just trying to get all my pieces here. So I work at the WHO Kobe Center in Kobe, Japan. And I am the objective. Does anybody know anything about the WHO Kobe Center? I came last year to talk, yes. So the objective of the WHO Kobe Center is to conduct research and synthesize evidence about health systems and innovations, particularly in light of population aging, to inform policy options and accelerate progress. So I've been in Kobe for just over a year, about a year and a half, and we've just started a new research plan where we're focusing on health systems, service delivery mechanisms, innovations, sustainable financing, and metrics and measurement. And we do have a special amount of resources to focus on collaborations with local universities. And so I think that includes Kobe as well as Kyoto and Osaka. So I do hope that we can have a broader collaboration over the long term in this area or any other area. What I'd like to talk about today is the theme. The theme of this year's conference includes the concept of health for all. So I would like to start by talking about health for all and what it means today in terms of our renewed commitments to the Alma Ata Declaration through universal health coverage. I'll present the WHO's assessment of what we have achieved so far in terms of universal health coverage. I'll then present the scope and some key principles of implementation research based on WHO's idea from the Alliance for Health Policy and Systems research. I'll then talk about the concept of causal pathways and identifying our assumptions and theories about how interventions work. I'm then going to give you a little story, which is a concrete example of an effectiveness study that was implemented in Mexico, and it's a study that I was a part of, and I think it's a very good example of some of the principles of implementation research, and I will make a small conclusion with some implications for us today. The title of your meeting is Implementation Research and Science for Health for All. So the concept of health for all is health as a basic human right was articulated as early as 1948 by the United Nations member states when they set forward the Universal Declaration of Human Rights. Subsequently, many countries embedded the right to health in their national constitutions, including Japan. Looking back at this time gives us an important perspective. By the 1940s, we had vaccines to prevent smallpox and yellow fever. Antibiotics and antimalarials were being mass-produced at the time. The 1950s and the 1960s brought the Salk poliovirus vaccine, oral contraceptives, and medicines for non-communicable diseases, including diabetes, cardiovascular diseases, and cancer. So by the 1970s, cost-effective medical products existed for many major diseases, yet these innovations were simply not accessible for the majority of people across the world who lacked not only access to these innovations, but also basic water and sanitation. So Health for All, as you've highlighted in your title of your conference today, was a key principle behind the Alma Ata Declaration of 1978. And represented a major milestone for public health in the 20th century. So this declaration was in fact an accumulation of efforts to make sure that equity was an important part of the global health agenda. In 2015, the UN member states renewed their commitment to the principles of health for all under the Sustainable Development Goals. I don't know if you've heard of the Sustainable Development Goals, but they are global goals established by the United Nations member states for 2030. And the SDGs include a commitment to the progressive realization of universal health coverage, including access to quality essential health services and safe, effective, quality, affordable, essential medical products and vaccines for all. So the question is, how are we doing? This is a commitment that we've had since 1978 or even earlier. Are we converting scientific findings to population-level differences? And are we implementing already proven and efficacious solutions to major health problems? Last year, the WHO and the World Bank issued a global monitoring report. So this is the box of, sorry, I skipped this one. This is the box of how we measure universal health coverage, where we look at the dimensions of coverage, who's covered, what services are they covered for, and who and how much is covered by the government primarily. So this are really the dimensions that we use to measure universal health coverage. The WHO and the World Bank issued their monitoring report on tracking UHC. The report uses 16 tracer conditions for 183 countries. These tracer conditions include reproductive health, immunization, infectious diseases, access to sanitation, normal blood pressure and glucose levels, cervical cancer screening, non-tobacco use, and health system capacity as measured by beds, health workforce, essential medicines, and the IHR, the International Regulations Core Capacity Index Score, which is a measure of how if health systems have the capacity to respond to outbreaks and emergencies. These 16 tracer conditions were summed up and presented on a scale from 0 to 100, with 100 presenting full coverage. The UH Service Coverage Index ranged from 22 to 86 across 183 countries with a median value of about 65. The map shows where coverage is high, as represented by dark green, indicating the coverage is 77 or higher, and the light green areas indicate the lowest levels of coverage at 45 or below. So as can be expected, you can see in this map, the index is highest in Europe, in North America, in Japan at 77 or higher, and lower in sub-Saharan Africa at 42 and Southern Asia at 53. The report estimates that the number of people with full coverage, the number of people who have full coverage of essential services range from 2.3 to 3.5 billion in 2015. So this implies that the number of people in need of at least one essential health services is about half of those 7.3 billion people in the world. So we have a very big problem in increasing access to basic services, water and sanitation, for about half of the world's population. This graph illustrates that the greatest need in absolute terms is for sanitation, hypertension control, and users of tobacco, where over 1 billion people each lack these kind of basic interventions to improve their health and address these health problems. The same WHO World Bank report looked at trends over time between 2000 and 2016. We see moderate progress with an estimated 20% increase in basic service coverage overall, but there is a huge variation by service. Quite substantial improvement in access to care for HIV treatment and access to insecticide-treated bed nets for those living in high-risk areas. We've seen moderate improvement in access to TB treatment, but the progress has leveled off. For the remainder of the indicators, progress has steadily increased, but we are not really on track to the ambitious goals that the United Nations member states set forward to achieve by 2030. The concept of health for all and universal coverage is about equities. And what we found in this report that inequality in access was stark. If we focus on 7 basic maternal and child health services, mothers from the poorest households, those with no education, and those living in rural areas had lower access to maternal and child health services compared with women from the wealthier households, higher education, and urban areas. And lastly, if you recall the definition of UHC, part of it is about coverage and the other part is about financial protection, with the commitment to ensure access in such a way that people don't face catastrophic spending when they try to access healthcare services. Some 11.7% of the global population, or about 800 million people, spend 10% or more on health as a share of total household income or consumption. And what's really remarkable is that we see increases over time. This increased from 9.7 to 11.7. We can say that increases in Africa and Asia is a function primarily of population growth. But we can also see increases in Latin America and Europe, which represent very much the difficulties in establishing effective financial protection systems. The report also found that about 97 million people worldwide became impoverished. They fell into poverty because of having to pay for health care that they needed. So in summary, the challenges are really great. You may have noted that the WHO's Basic Coverage Index shows countries such as the UK, US, and Japan as green, indicating access to basic clinical interventions that are already widely in use. This is primarily because the index is focused on access to basic health care that's widely available, and data are collected in most countries in the world. But evidence from more developed settings indicates that it still takes many years for new evidence to be put into practice. Implementation is variable, and it takes quite a bit of time. Several studies report that it takes an average of 17 years for new research evidence to reach clinical practice, and implementation frequently varies from place to place, even within the same region. We find in high-income settings as well that there are major gaps in using the findings from clinical and health services research to actual practice. So needless to say, we still have quite a long way to go in terms of adopting evidence-based practices throughout the health system and by healthcare professionals. And this represents a major barrier in improving population health across the world, regardless of income levels. So this is where implementation research comes into play. Very simply, implementation research aims to bridge the gap between the interventions that are efficacious in controlled settings and their application in the real world. There are many differences across different agencies about the definition and scope of implementation research. So I relied on the WHO Alliance for Health Policy and Systems, who've recently published some guidelines on implementation research. And it emphasizes, the WHO Alliance emphasizes the study of how specific interventions can be translated into broader policies and programs. It still sets forth a very broad scope, encompassing any aspect of implementation, factors affecting implementation, process and results of implementation, including how to introduce potential health solutions into the health system, and how to promote their large-scale use and sustainability. This graph emphasizes the operational aspects of implementation, but also the wide range of outcomes, including feasibility, sustainability, uptake, and equity, among others. Again, these are outcomes that answer the more important questions for decision makers, healthcare workers, and users of the intervention. I selected a few key principles set forth by the Alliance for Health Policy and System Research that I will reiterate throughout the presentation. Outcomes, as we've mentioned, typically include cost, coverage, adoptability, acceptability in communities, appropriateness for context, feasibility, and sustainability. Results are targeted toward meeting the needs of the users of the research, whether they're policymakers, health workers, or communities. And there's less emphasis on solely the production of research knowledge. So the key here is to work with people who are going to utilize the research to determine the most appropriate outcome that we're measuring. And understanding is needed in the conditions in which an intervention is implemented, whether it's a social setting, political setting, economic conditions, institutional context, or structure of the health system, for example. Typically in health systems research, a specific intervention has been shown to be effective in certain patient populations that they may have a very different effect in other patient populations. This is particularly true when we work in international development and we're targeting populations that may be marginalized, or in the case of WKC, we look at populations with multimorbidities. And these populations may be explicitly excluded from populations studied in more controlled settings. Similarly, the implementation research does not apply any specific methods. Rather, the research questions itself determine the most appropriate methodologies, whether it's pragmatic trials or effectiveness trials, quality improvement studies, or mixed methods. So I have just to reinforce this point, this is a slide from a training on implementation research done by the WHO TDR, the Tropical Disease Research Group in our WHO headquarters, which give examples of some research designs based on need or level of inference required from a programmatic perspective. So in this table, for example, where the objective is adequacy, we wish to understand with sufficient confidence that the intervention and outcomes are occurring. So in this example, the question is coverage of health insurance changing access or improving access among the intended beneficiaries? And then this determines the research design, before and after or time series, in intervention recipients, or as well as possibly participatory action research, so we can understand the pathways. Where the need is plausibility, we seek to understand with greater confidence that the health outcome is due to the intervention. So in this example, the question is, does a new approach to MCH services in selected districts improve maternal and child health outcomes? And can an improvement in health outcomes be plausibly attributed to the implemented innovation rather than some other cause? The study question would imply non-randomized control, non-randomized cluster trials with the health intervention implemented in some areas and not in other comparable areas, before-after studies or cross-sectional studies in program recipients and non-recipients, or quality improvement studies, for example. Where the need is probability, we need to understand with some higher level of certainty that the outcome is due to the intervention. So in this example, we'd like to know whether mobile phone use increases adherence treatment treatment for tuberculosis. So a stronger level of inference requires a more rigorous design, such as partially controlled trials, pragmatic and cluster randomized trials, and effectiveness implementation studies, for example. So the point I'm making here is that there are many research designs that are viable, and that the research question is the starting point of determining the research design. I would like to specifically talk about the concept of causal pathways, where we map out the process by which any intervention may work. So even among very basic interventions, the causal pathways from an activity, medicine, or technology to a health outcome can actually be very complex. And particularly for some health systems interventions and policies, we see a rather complicated process from the intervention to the health outcome. This is a causal pathway for the WHO IMCI program, the Integrated Management of Childhood Illnesses. So the main intervention was one of the most common and straightforward interventions that we have in health services, is health worker training. So in this pathway, after a training is conducted, we assume that the health worker has increased knowledge, that knowledge is applied in a clinical setting, and translated to improved quality of clinical care, and that improved quality of clinical care is translated to better patient outcomes through, for example, better care-seeking behaviors, higher utilization, improved prevention practices, and full and complete patient compliance with health worker recommendations. So what do you think could possibly go wrong with this pathway? So this is the result, the actual result in Peru of the IMCI training program. So we see that there was a training of health workers and we had increased training coverage, but all of the assumptions the rest of the assumptions proved to be false. Particularly for health systems and multiple packages of interventions that we have in the real world, it is critical to think through how you expect it to work. What are the causal pathways? What are the health systems assumptions that we're making? How will the patients and communities respond? And this usually involves thinking through not only beneficial outcomes that we want, but also possible adverse or unintended effects. People do not always respond in the way that we expect, whether it's health workers or patients. What I'd like to do right now is tell you a small story and give you a concrete example of an effectiveness evaluation. This is called the Oportunidades Conditional Cash Transfer Program in Mexico. Has anybody ever heard of this program? Has anybody ever heard of conditional cash transfers? It's a large-scale social program. So that's good. This is a program in Mexico, and I think it's it illustrates some of the principles of implementation research, and it's a program that I myself was involved in, so I'd like to use it today. The underlying theory behind conditional cash transfer programs in Mexico and globally was that poverty and health inequalities are intergenerational. So this is one of the biggest challenges in facing health inequities because it's very difficult to break this cycle of poverty and poor health. Children who are born poor or born with few opportunities early in life face constraints in their learning opportunities and their professional development. So I think this is one of the biggest challenges, how we can break this cycle of poverty and inequalities so that we can leapfrog progress, particularly in terms of our Health for All agenda. Mexico is a middle-income country, but there are huge economic and health inequalities that manifest themselves in health outcomes. Take child stunting, for example. In the southern region of Mexico, as many as 44% of children under 5 years are stunted. So this is related to poor nutrition as well as repeated or untreated illnesses. So we see, for example, high rates of stunting among children with low access to basic services and food insecurity. Generally, it's difficult to reverse stunting. It's not impossible, but generally it's difficult to reverse stunting in adolescence, particularly with no specific interventions. So this results in the pattern seen here, where we see that adult height is correlated with income decile, with 1 being the poorest adults and 10 being the wealthiest adults. The government therefore designed a conditional cash transfer program that was intended to have both short-term and long-term effects. Over the short term, the cash transferred were provided to poor households to address their immediate needs, including food security, medical care, and improved living conditions. Over the long term, the cash was conditional on accepting health, education, and nutrition benefits, all of which were expected to have benefits over the long terms by investing in a child's early life, thus focusing on physical and mental capabilities that were predicted to have a much longer and lasting effect. The cash transfer was for health and education. The health transfer was about $15 per month, and the education transfer depended on the number of children, whether the child was in primary school or secondary school, whether the child was male or female, where households with female children were given higher transfers because girls were more likely to drop out of school. The educational transfer was conditional on 85% attendance. The maximum monthly benefit for health and education combined was $90 for families with primary school children and $160 for families with secondary school children. So this amounted to quite a substantial level of additional resources for poor households in Mexico that we estimate will increase their income by about 20%. It was given to the mother as primary fund holder, who is traditionally responsible for health and education of the children as a family. The cash transfer was conditional. This meant that to receive the cash, the beneficiaries had to agree to get health education, health care and nutritional supplements. Pregnant women, for example, this is just a few examples of the conditions. Women were required to obtain prenatal care and accept nutrition and monitoring supplements with full daily required micronutrients. Young children were also required to go to public health clinics for curative care and monitoring and provided nutritional supplements. Eligibility was determined in 2 stages through household surveys, first by identifying poor communities, and then within those communities, surveys were done with individual households. The initial program was very large. The initial program in rural areas was planned for 3 years, from 1997 to 2000, including some 2.6 million families from 50,000 villages, which amounted to about 40% of rural families. There was a very high take-up rate. Family received benefits for about 3 years, conditional on meeting the program requirements, and moreover, there was a re-enrollment every 3 years. The initial program was expected to ensure that the families who were accepted into the program and complied with the benefits would receive these benefits for at least 9 years. There was, however, a political economy problem. A program of this size required a very high level of political commitment, and there was an election planned in 2000, which threatened the program that was designed to last for 9 years. Normally, because of the election cycle, there's a reluctance to spend on investments that have a long-term return, such as child health and nutrition. And this is not a problem that's limited to Mexico, but many countries in which political change can imply stopping programs or halting large-scale programs that were designed by the previous administrations. At the same time, the organizers had an implementation challenge. They faced budget constraints prohibiting the implementation of the program all at once. The government didn't have enough money to give benefits to all eligible households in the first year of the program, so they had to figure out how to phase in the program over 3 years. So the government partnered with researchers to carry out an effectiveness study to determine feasibility, scalability, and impact. If the program were able to demonstrate an impact, it could ensure that the program survived, even if there was a change in the political administration. So the government invited a large research team involving both global and national researchers to carry out a study. Typically, we know that randomization is very difficult in real-world settings. However, researchers in this case convinced the policymakers to use randomization at community level as a fair way to expand a large program. So among the 506 communities that were selected, about 2/3 received the benefits first and another 1/3 received the benefits 2 years later. This enabled the researchers to designate the first set of communities as treatment communities and the second set as control communities. There was also a very large-scale household survey that was done. So we had a baseline survey and then a follow-up survey 2 years later. And this was complemented by structured interviews and focus groups to look very closely at implementation. And the results were very impressive. Over the first 2 years of the project, beneficiaries increased their utilization of basic services, and children had a lower incidence of illness and anemia. Children who started the program 2 years earlier in comparison with the control beneficiaries were also assessed as taller, as measured by, had increases in growth rates. And after 5 years, the study confirmed large reductions in stunting, 22% among boys and 34% among females. So this, that's the source. I use this example because I believe it's one of the best examples of successful partnership with decision makers to inform questions related to feasibility and scalability. The researchers were able to partner with the program implementers and design the research prospectively, hand in hand with the program rollout. The random assignment of communities was desirable from both a program implementation perspective and a research perspective. Randomization was presented as a fair way to implement a large-scale program facing budget constraints and enabled a prospective study design. The large-scale investments in data enabled many studies on the implementation of the different arms of the research of the program, and modifications in the program were subsequently implemented. And most importantly, a new government was elected in 2000, and instead of stopping the program, they expanded it to 2 million additional families. It was still in place in 2015, and the strength of the findings endured the subsequent changes in administration and political administration, and a form of the same program is still operating today in Mexico. So the research was very effective in addressing the political economy problem by showing a very positive impact, thereby addressing the questions of feasibility and enabled scaling up nationally. Ultimately, research informed the adoption of similar conditional cash transfer programs in many other countries. We see examples here in green: South America, Southeast Asia, the Middle East, and even in New York City. Many of these also adopted the approach of studying the implementation aspects, particularly those that were controversial in different settings. The conditionalities, for example, monitoring compliance. In Mexico, they transferred funds to the female head of household, which proved to be controversial in other settings. And of course, the amount of funding that's needed to make a difference in health outcomes. And some of this research was done alongside the implementation as well. So in closing, I would just like to go back to the concept of health for all and universal health coverage. While we have made significant progress since 1978, we are facing the challenge that at least half of the world's population lack full coverage of essential health services. Great inequities remain, both across and within countries. Across countries, the gap in life expectancy is stark. A child born in Japan is expected to live nearly 34 years longer than one born in Sierra Leone. And low and middle income countries are facing the challenges of increasing inequities with wide gaps based on income. While we need new innovations and technologies, there are at the same time many existing clinical interventions, medicines, and vaccines that are efficacious but not yet converted into population-level health improvements. And I think this is the challenge that is at the very heart of the concept of sustainable development and universal health coverage and health for all. In designing the research, I would emphasize the importance of challenging your assumptions and think through how you understand specific interventions, how they're supposed to work, where the variations and implementation may likely occur. Such types of causal pathways can assist in monitoring to even tell you when an implementation is sufficiently implemented to justify further study. Implementation research is fundamentally about problem solving. While descriptive research helps to identify and describe problems such as system barriers, we also need to think through better implementation. This implies studying solutions to understand how to address system barriers and challenges to increase access to what we know works already, as well as the introduction of new innovations. The most important aspect of implementation research, in my view, is that it implies major changes in how researchers work. I've given the example of the Oportunidades program in Mexico because I think this is really the best example of the fundamental change in how researchers interact with decision makers, or as our previous colleague was talking about, bureaucrats and how bureaucrats think and how we think quite differently. We are taught as researchers that objectivity and independence are critical parts of doing research, and sometimes this results in academics taking great pride in not having contact with implementing agencies or governments. Implementation research, however, requires a very different approach because you need to understand very clearly the design and implementation of any intervention. For example, program placement. Program placement is one of the biggest problems to study in implementation research. Decision makers allocate programs, they allocate innovations based on specific needs and criteria. For example, a decision can be made to allocate an intervention to a poor region where the need is the greatest. Or conversely, an innovation can be allocated to a well-functioning region where the decision maker is under pressure to show success. Either way, you need to understand these decisions in order to do good research and establish what we call a counterfactual. What would happen if the intervention had not taken place? This implies very practically that you need to interact and talk with local decision makers, local government, and involve health workers and communities as a part of designing your studies. And only by doing so can you fully understand the steps and decisions in which a program was implemented and how benefits were allocated. This is not to say that objectivity and independence are not important, and even the perceptions that researchers are not objective can influence the acceptability of findings. But you can mitigate these risks through identifying and declaring conflicts of interest and then creating external technical review panels, for example. Independence and objectivity are not sacrificed by ongoing engagement and communication. And such engagement is a critical part of designing good implementation research and increases the likelihood the findings will be used. These results have to be believable among people who have the resources and the ability to put your findings into practice. Ultimately, the success of implementation research is not only about whether you publish, but the true test is whether the research itself is used by decision makers in support of better implementation. Thank you very much.